So now we are going to speak about the clinical presentation of sickle cell patients. Clinical presentation. Now, for the clinical presentation of patients that have sickle cell, you need to know that there are different elements that you have to speak about. So we have spoken about here you receive a pediatric patient and then you have different elements. Is it clear? Generally, the patient are going to, let's say that is the first time that the patient is diagnosed sickle cell. Is it clear? The patient is going to present with a history. You have a patient that has elements like frontal bossing, parietal bossing. He has also long tapering fingers that I've forgotten to tell you. Frontal bossing, patient with frontal bossing, parietal bossing, icterus. So icterus, the eyes are jaundiced. We have long tapering fingers. Long tapering fingers still come as a result of the excessive hematopoietic production. Is it clear? So long tapering fingers. So if you have all the patient with all those characteristics, now present now with a different crisis. Generally, patients that have sickle cell are going to present particularly with crisis. Is it clear? So they can present acutely. Is it clear? Acutely with crisis. Now, when you present acutely with crisis, you have to think so you can have acute crisis like vaso-occlusive crisis. So when there is pain at the level of the joint, at the level of the distal part of the body, is it clear? Or you can see present as an acute chest syndrome, like the pain at the level of the chest. Is it clear? When you have already an element of like acute chest syndrome, it is an emergency. And every time you have patient with acute chest syndrome, you're going to continue with a particular management, particularly hydroxyurea, as I'm going to explain the management. Now, if you have sequestration crisis, the patient is going to complain of pain at the level of the right hypochondriac region. Is it clear? And the patient generally become hypotensive because of his mild hemorrhage and also sequestration of blood inside the spleen. Is it clear? You have aplastic anemia, the patient is becoming anemic on physical examination. Also, I forgot to in sequestration crisis, when you do physical examination, they have the spleen is very enlarged. Is it clear? You have hypotension. Aplastic anemia, you have the patient can be infected, the patient has bleeding symptoms, and then the patient is anemic, has signs of anemia. Those are the three in aplastic because of the pancytopenia. In hemolytic crisis, the patient is going to present both with jaundice and also going to present with anemia. So clinical signs of anemia. So generally, those are the elements that you have to see in the crisis when you receive patient with a acute crisis. And also hand-foot syndrome, the swelling of the hands and the foot can occur in this patient. Is it clear? Now, there are chronic complications that you need to understand. So, the chronic complication, you are going to have chronic hemolysis. Generally, these patients are going to have a chronic hemolysis, as I've just explained. The next one, you have stroke. Every time you have a pediatric patient that has stroke, you should need to know that there is a background, or there can be a background of sickle cell. Chronic otitis media, and we have also chronic osteomyelitis. It is very common in patients with sickle cell. Every time you have a child that has osteomyelitis, it's always good to check for the sickle cell, because we have said that there is a functional asplenia. Is it clear? And thus their immune system is going to be reduced. We have also heart failure. Is it clear? So heart failure can occur still if you have a patient that has heart failure. Is it clear? You can think of sickle cell. Pulmonary embolism in a child with other thromboembolic event. We have parietal bossings and all that. We have functional asplenia with a child that is usually has infections. Is it clear? It can make you think of a sickle cell anemia. A child that is usually urinating on himself, has polyuria with renal papillary necrosis, can make you think of sickle cell anemia. So those are the different presentations that you can have. A child that has pain, a cholecystitis at his young age because of the gallbladder stones, he has sickle cell. A child that has chronic leg ulcers, is it clear already? We can think of sickle cell, is it clear? And priapism. So those are the different elements on physical examination and clinical examination that can tend you towards your diagnosis. And now, how do you make a diagnosis now?